Hi, good morning, everyone. It's my pleasure to introduce today's speaker, Dr. Bhavin Modi. Dr. Modi is a PGY5 and chief resident in our child neurology program. He is a native of Birmingham, Alabama, and earned his Doctor of Medicine from the University of Alabama at Birmingham School of Medicine. He also completed both his Master of Science in Biomedical and Health Sciences and his Bachelor of Science in Molecular Biology and Psychology with a focus in neuroscience at the University of Alabama at Birmingham. Following graduation from his residency, he will be pursuing epilepsy fellowship here at Barrow, Phoenix Children's. And Dr. Modi's clinical interests include epilepsy, neurogenetics, movement disorders, and neuroimmunology. And thank you for being here this morning, Dr. Modi. We look forward to your talk on movement disorders from genetic diagnosis to different targeted treatment modalities.
Yeah. Thank you so much for having me. Excited to be here and do this. So my topic will be precision medicine and pediatric movement disorders. We'll discuss genetic diagnoses and then also therapies and then DBS as part of the therapies. So here are the objectives. Once again, we'll talk about what the role of precision medicine is. We'll discuss the some of the major genetic disorders or some examples of them and their current treatments, and then we'll discuss along with that, we'll discuss DBS and how that's used in treatment, and then of course we'll talk about some future things as well. So what is a movement disorder? So, any disorder that causes abnormal movements, right? So either it's too much, too little, or inability to control the movement. This can be issues either initiating, executing, or stopping the movement. So a very basic schematic here of the neuroanatomy, just to kind of lay the framework. Obviously, it's a lot more intricate than this, but movements, initiated in the motor cortex. Of course, you have the premotor cortex, the SMA area that helps guide those movements. But then, as we go down into the basal ganglia, the thalamus, which is where you'll see later where a lot of our treatments work or targeted towards. And then, of course, we get into the spinal tract. Of course, the cerebellum is also involved, and then finally we get to the muscles for the production of the movement. But once again, a very basic schematic. So in contrast to precision medicine, what is the alternative? So empirical medicine would be that. That is treatments that are based on population averages. So studies that we've done where we know that on average this works better than the placebo or the current gold standard. And we have guidelines or general guidelines. So that would be empirical medicine. Or another way to think about it would be a one size fits all. In contrast, precision medicine would be where we are basing the treatment based on subgroups, not necessarily always an individual, but subgroups and sometimes individuals, but their genetic makeup, their molecular makeup, and or environmental profile. The advantages potentially, we'll touch more on this later as well, but our goal would be to hopefully reduce trial and error, right? Because we're doing a targeted focused treatment. So this hopefully helps reduce trial and error and then minimize adverse effects once again because we're doing targeted treatment. So hopefully it's minimizing the adverse effects. And then our hope would be that it is overall very effective. Disadvantages, which once again we'll go more into later, but would be the high initial costs and then also limited access. So what what composes precision medicine? So, the first thing would be the genes or the proteins, the metabolites, or even at the transcription translational level. So, basically, the central dogma of molecular biology, right? So, that would be a major component of precision medicine, which is where most of the talk's going to be today. But the other thing we also use, and I think this is probably more used also like in our epilepsy world, but neuroimaging, right, where we are doing targeted therapies. But imaging can, of course, be used in movement disorders as well. Just a one example of kind of like what is precision medicine, just to once again lay that framework of precision medicine, and then we'll get more into details of movement disorders. But this medicine right here, ivacaftor, it works specifically for this class 3 mutation. So it's not a drug that works for all patients with cystic fibrosis, but rather just the patients who have this one specific mutation right here, class 3. And so that would be a example of how we're using targeted therapy for a certain specific subgroup of patients within a certain disease. And so then that also uh, makes us want to talk about how diseases are classified, right? So we either have the traditional taxonomy where diseases are structured or classified based on clinical symptoms and our physical exams, and then we use, empirical medicine to use our and use the guidelines to provide the treatment versus precision medicine, so treatment based on the patient or the subgroup of patients. For example, if we were to do PET imaging for beta amyloid, targeting treatment towards that, versus for Alzheimer's patients who may have the ApoE gene, targeting treatment towards that, or targeting treatment based on the tau protein concentration. Obviously, many of these are adult neurological disorders, but just some examples of how we could use precision taxonomy. And then, of course, why use precision medicine, pediatric movement disorders? So, there are greater than 400 genes that have been identified in pediatric movement disorders, but a lot of them have significant overlap in the phenotype, right, or the clinical presentation. And so, using precision medicine, specifically a lot of genetics, we can hopefully treat the disease with disease-specific therapies. So, what is the importance of early genetic diagnoses, right? So, once again, a major component of precision medicine. So, the goal would be that we are ending the diagnostic odyssey, right? So, a lot of patients who go undiagnosed for years because of a rare disease, hopefully, it is lessening the burden if we are doing more targeted diagnostics and treatment. Hopefully, it can help us understand the prognosis of a certain disease, recurrence risk once again, targeted therapies if we know the genetic disorder. And if there is gene therapy for that, then we can target that, correct? And then DBS selection, which we'll go more into as well. And then lastly, of course, clinical trial eligibility. And so, how do we implement precision medicine in movement disorders? So, the first one, gene therapy, which I absolutely love. Gene therapy is defined as any therapy to treat or prevent or cure a disease. Using gene therapy, we can either do this by adding new copies of a gene, we can replace the defective gene, or we can edit a gene. And so we'll go kind of into the details of this. So once again, the basics. So what can we do? We can once again replace the defective gene. We can also silence gene expression, and then we can also do CRISPR, so gene editing. So, how is gene replacement therapy done typically? So, one way would be we take out the stem cells out of a patient's bone marrow or blood, or I guess in baby's umbilical cord, and then also then to move on to the next step, stem cells are then grown in the lab. We use a viral vector, and then the gene is inserted into the host cells. And then, based on different mechanisms, we can the using a particular vector, the functional copy of the gene, once again, is in the host cells and hopefully producing a functional protein. And then the other method would be direct injection approaches as well, which we will talk about in just a bit as well with one of our examples of a genetic movement disorder. Just for completeness sake, so the common vectors that we use are retroviral, or we could do adenoviral vectors, and then also adeno-associated viral vectors. We will not go into the details of each one. They all have their advantages and disadvantages. Um, But these would be some of the vectors we use. I'm sure, as a lot of you know, the adenosine viral vectors are probably the more popular ones right now, especially in Huntington disease. I believe that is the vector they're using for that trial, but we'll go into that as well a little bit later. And then another way to for gene therapy to work, we could do gene silencing, right? So we could do it at the transcription level. So we can methylate the DNA, right? So that mutes the DNA, as we're all taught in medical school. Methylation of the gene, or we can bind specific parts of the DNA with small interfering RNA. Then that blocks the production of a defective protein, right? So that's at the transcription level. Then we also have the post-transcription level or translational level, right? So once again, synthetic RNA that can target the mRNA that's produced by the host cells, which would result in a defective protein. But if we block the mRNA, then the defective protein is not being produced. A little more details about that. So ASOs, I think, would be a good time to talk about that. So with gene silencing, so these are the two major mechanisms of how ASOs work. As you can see in the first mechanism, you have the antisense oligonucleotide binding to a specific sequence of the mRNA, which then recruits an enzyme, which leads to destruction of that portion of the mRNA that is responsible for producing the defective protein. And then, so now we have this new mRNA that hopefully does not produce the defective protein. And then we also have exon skipping. So this would involve blocking a specific splicing site, once again, to produce a functional protein. And as I'm sure many of our neuromuscular specialists will recognize many of these names, but a lot of this is used, of course, in neuromuscular medicine. And then lastly, as far as gene therapy, so gene editing, so CRISPR. Thinking of this as like an enzyme or with scissors, right? So the interest or the gene of interest is modified by an enzyme it's cut out, and so gene editing. Okay, next. So DBS. Just to kind of touch on the neurophysiology. By no means am I an expert in this, but I will try my best to break it down simplistically. Um, we have a usually a four contact electrode that is typically inserted via neurosurgery or stereotactically. And then there is a subcutaneous wire, which would be connected to the IPG or the implantable pulse generator that is usually underneath the chest. And that is sort of the, quote unquote, brain pacemaker, or it is what fires the electrical potentials or impulses. And then there's a handheld device that wirelessly communicates with the IPG. A little bit more about the neurophysiology. So there are multiple configurations. One of them being the monopolar configuration in which a single electrode is inserted, which is the cathode, and then the IPG or the impulse pulse generator would be the anode. Um, the this would be a more of a broader electrical field that it creates just because of the distance, right? And then you have the bipolar configuration as well. So with this, it's two electrodes that are inserted. So one is would act as a cathode and the other one would act as the anode. And then this provides a more concentrated, more focused, right? So here's a schematic of that. So picture A shows just the insertion of the DBS, and then B shows the monopolar configuration, which shows, as you can see, that it is a much broader electrical field and less concentrated, versus in the bipolar, as you can see, it is more concentrated between the two, or the anode and the cathode. And then, of course, clinically speaking, this can be adjusted, right? So the the stimulation can be adjusted by the clinician or the neurologist doing this. The pulse width can be adjusted, and then the frequency. So, but that would be all done after placement and then clinically. And then kind of how this works is basically now this is now firing action potentials or blocking the quote unquote bad ones. So yeah, just little basics on DBS neurophysiology. And then to end that, would be local field potential. So these are low frequency signals that the patient's brain itself is generating or creating, and is recorded by DBS while also stimulating as well. So DBS is recording what the patient's brain is doing at baseline, what are the abnormal action potentials or what is not being fired, and then DBS can be hopefully altered to that specific patient, and the settings can be adjusted. Um, there was a longitudinal clinical study, actually, I believe it was published in 2025, that did show that local field potential surveys can help detect or select optimal DBS settings. And so, once again, maximizing benefits but minimizing side effects or precision medicine. Now, DBS in pediatrics. So, the only FDA approved indication in pediatrics is refractory dystonia in children who are 7 years or older. Otherwise, the DBS that we use is all off-label, but and we'll talk about some of those things that we do. But in movement disorders, the only FDA approval is for refractory dystonia. Currently, there are greater than 400 clinical trials on DBS. Um, Majority of them, of course, are in adults. I believe only four are in children, so uh, significantly less in children. But so hopefully, those four will hopefully come out with more. Or yeah, more FDA approved indications, but the only one currently is the refractory dystonia. And then multiple sites we can use for insertion of the DBS. So here's just a schematic to show some of these parts, but there's the globus pallidus, so there's subthalamic nuclei, putamen, caudate, so multiple areas of interest or also insertion, and they all different areas are used for different disorders. So I believe for Parkinsonism, it's the subthalamic nuclei. Um, and then for dystonia, I know globus pallidus can be used. So a lot of different sites that can be used and results in different outcomes. And so just basics of pediatric movement disorders. So of course we can break them down into hyperkinetic versus hypokinetic. As we know that in pediatrics, hyperkinetic movement disorders are significantly more common. I tried to find like a breakdown of how much, like is it 90-10 or 80-20 or something, and I was unable to find that. But I did find that majority of the movement disorders in pediatrics would be tics, followed by tremor, chorea, and then dystonia. To my surprise, dystonia was lower on the as far as frequency. Um, but yeah, tics would be the most common. And then, of course, hypokinetic disorders do exist in children, very rare. But Parkinsonism or juvenile Parkinsonism can be seen in pediatrics. Once again, very rare, but possible. And now, towards the end of this, so to kind of discuss some examples of genetic movement disorders and their current treatments, some of which I guess would be considered treatable versus not treatable, but symptomatic treatment. Um, so the first one I have is dopa responsive dystonia. This is in which children develop dystonia usually early in childhood that starts in the lower extremities and then can progress to involve the upper extremities. There's of course rigidity and then Parkinsonism as well could be involved or seen. This is a mutation in the gene that leads to a defective GTP hydrolase. As this picture is showing, it is involved in production of this metabolite right here, tetrahydrobiopterin, which is required for the production of dopamine. And so this mutation once again leads to that defective enzyme, and so you don't get tetrahydrobiopterin. But treatment for this is levodopa, and from what I've read, clinically I don't have experience in this, but from what I've read, up to 70% of patients with this respond very well to levodopa. Another example, so Wilson disease, showing examples of how we're using genetic testing to identify particular movement disorders. So Wilson disease, once again, we have dystonia, tremor, Parkinsonism. As you can see, very similar phenotype to the prior disorder that I talked about, but this is a different mutation. It's a mutation within the liver cells, or in specifically the transporter for copper. So the copper is able to get into the hepatocytes. However, the transporter within the hepatocytes that is responsible for getting it transferred further down is what's defective, or the ATP7B gene is defective. And so treatment would be listed here, the penicillamine, trientine, or zinc. But once again, as you can see, very similar phenotype as well, right? Next one, neurodegeneration with brain iron accumulation, developmental delay, Parkinsonism, seizures, dystonia, tremors, some of the major symptoms of this. But this is a mutation in the PANK2, or it can also be a mutation in the PLA2G6 gene. And so the defect is in the pantothenic kinase, and so it leads to these symptoms. And this MRI is the classic eye of the tiger sign, if you will, which is what the arrows are pointing to. But it's the iron accumulation, and DBS can actually be used for this, or I guess off-label we use this. Next example I have is the ADCY5 related dyskinesia. So again, similar symptoms, dystonia, tremors. Something unique about this is that it can also occur during sleep. And this is a mutation in the gene that is responsible for producing adenyl cyclase, which that enzyme is responsible for converting ATP into cyclic AMP. And so with that defective gene, we are not able to get to AMP. And so some of the treatments would include caffeine, as we know that acts on adenyl cyclase, or that system, and then some other options as well. Then I have the aromatic L-amino acid decarboxylase deficiency example as well. Once again, dystonia as a symptom. This is a mutation in the gene responsible for producing these neurotransmitters, notably dopamine. And so with this, though, we do have gene therapy. I will not attempt to pronounce the name of that gene therapy because I know I will butcher it, so I apologize. But we do have gene therapy for this, and it is actually delivered. So it's inserted surgically, stereotactic neurosurgery into the putamen, particularly, and so currently we do have this. Along with other ways to treat as well, so such as dopamine agonists or the MAO inhibitors. And to not leave out our adult colleagues, if any of them are joining. So Huntington disease, the symptoms, of course, are probably a lot more different, but chorea, there's that emotional, the neuropsychiatric features, right? But cause of this is the trinucleotide repeat expansion and the Huntington gene. Treatment can be the tetrabenazine or antipsychotics, SSRIs for the neuropsychiatric features. But there is the AMT 130 clinical trial that is using gene therapy to potentially treat this. And so the point of this gene therapy is to there's a microRNA that it hopefully will silence the mutant RNA, or the RNA that is mutated, thus blocking the production of the defective Huntington protein. Currently in the clinical trial, it shows that there is a 75% decrease in disease progression. And then the last example I have for genetic movement disorder, as the DYT1. Once again, dystonia is a major symptom. This is a mutation in the torsin 8 protein. I believe at the moment it's like it's unknown function, but it's thought to be involved in cell transport. And treatment with DBS, and then I do remember reading that up to 70% do respond well with reduction in the dystonia. And so the future or some emerging therapies for DBS, once again, these would be all off-label, but there are studies being done. So self-injurious behaviors, to my surprise, that's something that we are trying DBS for. They're a very small study, but 6 children with self-injurious behaviors. There was a study done in which the DBS was placed on the nucleus accumbens. And at 12 months, there was a significant decrease in the self-injurious behaviors, which obviously led to better quality of life. And then, of course, less injuries. And then acquired dystonia, so TBIs, we know that can, of course, lead to dystonia that would be acquired, so treatment for that. Cerebral palsy, one study that I read, it didn't necessarily help with the cerebral palsy itself, but it did say that people who they did report better quality in the sense that they had less pain, better comfort, their school attendance went up, and then they were better able to like sit in school. And so in some way it was effective, but not necessarily didn't necessarily improve the movement disorder itself. And then drug-resistant epilepsy. They was one study I read that there were 18 patients in a randomized patient preference trial that showed that patients with VNS for 12 months with no benefit showed reduction in seizures after DBS was added on, rather than optimizing VNS itself further. It wasn't a DBS versus a VNS study, but a DBS add-on to the VNS. And so, lastly, some of the benefits of precision medicine. So, the initial costs can be high. As you can tell, genetic tests are very expensive. I actually just encountered this last week in one of my continuity clinic patients, and I was surprised at how expensive it was. I had ordered a epilepsy gene panel, and insurance declined the cost, and the out-of-pocket expense that I was quoted was greater than 25,000 for the patient. So I was very surprised how expensive epilepsy panel was, but initial costs can be very expensive. However, the potentially could be offset by the fact that we have reduced incidence of adverse drug reactions, which would hopefully reduce hospitalizations or clinic visits, and complications, right? So, and then hopefully also just improve treatment efficacy. If this is a targeted treatment towards that patient's specific genetic mutation, then hopefully it works better for them than the standard treatment that's would be a one size fits all. And then once again, also we can another way for cost effectiveness would be, or the benefit of that would be that we are also selecting patients that we know would benefit from a particular therapy. For example, the AADC mutation, we're only going to select certain patients who have that mutation who would benefit from the gene therapy. So while yes, gene therapy itself could be expensive, we are not using it for everyone, right? So hopefully that once again kind of helps with the cost effectiveness. Now, the concerns with precision medicine would be, or some of the flaws, if you will, would be that it could amplify health disparities, right? So these major treatments, such as gene therapy, or these even just the basic to even get to the diagnosis, the genetic tests are most likely available at big academic institutions or large cities, very less likely to be or unlikely to be available in smaller cities or rural areas. So once again, it does kind of, unfortunately amplify those health disparities. Um, and then empirical medicine or the standard treatment, the one size fits all is probably more readily available in underserved areas or rural areas. So, and then so also lastly, as I was looking up, I was trying to pull up a specific dollar amount as to like how much is the cost effectiveness, but specifically in pediatric movement disorders, there is no specific amount. But in movement disorder, there is a moderate cost effectiveness. But I did see that in many other areas of medicine, that's not necessarily the case, and precision medicine actually ends up being more expensive than the empirical treatment. But obviously did not go into a lot of details in the other parts of those areas, but I'm sure that the outcomes are hopefully better, even though it was more expensive. So patient oriented, right? So, um, but that is all I have. So thank you so much for joining. And I do see there's some chats, so I will open those up and see if there's any questions. But I also am open to questions at this time. Dr. Kaur is asking if we are doing the gene therapy for AADC deficiency. Not to my knowledge, but if there's any expert in the audience who knows the answer to that, but not to my knowledge. Okay, and Dr. Greeby states that Access does cover genetic testing for those whose insurance does not cover testing. Okay, and then a question about severe dystonia due to autoimmune encephalitis who needed DBS for his drug-resistant dystonia. I do not have any specific data just for that, but that is a good question. But I do not have anything specific at the moment. Yeah, I think, yeah. So those are the only questions or comments that I see in the chat. But if anyone has any questions they'd like to ask or comments.
That was an excellent job, Dr. Modi. Very, very nice, very comprehensive. Do you know if there's going to be any, if there's any more help in getting precision medicine for how medications react in general in people rather than necessarily with just the specific gene? I know that obviously there's
Yeah.
some fields that do that. Psychiatry does that already.
Yeah.
A lot of other fields. We have a lot of medications where certain kids have horrible reactions and others don't. What
Yeah.
is your thoughts on that?
Actually, I love this question because I recently actually encountered this. So, when I was on inpatient a few months ago, I did have a family that had requested that, is there any way we can test whether their child would have DRESS or Stevens-Johnson? I believe the patient was admitted for Stevens-Johnson, if I'm not wrong, due to one of our anti-seizure medications. And it was also not one that we typically would associate with. So, I mean, of course they all are, but lower on the list was my point. But so I reached out to allergy immunology to see. My thought was that I know that they do allergy testing, right? But I would expect those are more type 1 hypersensitive reactions, right? The IgE mediated, not necessarily the ones that drug reactions are, which tend to be more type 4 or and so I did ask them, and they said they could potentially test, but it's not something that we clinically do. Just of the mixed, from my understanding, I think it was mixed data are not very useful. And even just because they have a particular gene that we know is associated with a higher risk of a particular adverse effect, doesn't necessarily mean that they would definitely get it, right? So. But that was the answer that I was given, and it made sense, right? I don't think at the moment we have anything that could specifically check for anything like, oh, would this patient have DRESS or Stevens-Johnson? But I guess maybe one day.
Thank you. Appreciate it. I think there's one more
Any,
question in the chat.
yes, any utility in modifying these electrodes to have a higher number of modulating points, would that increase precision? Would that impact side effect profiles? I would think so. I am not an expert in that, but I would think so. But if Dr. Kruger or Dr. Bhatia are in the audience and if they know the answer to that, I would appreciate their help. Yeah. So I think to answer the question, I don't know. I don't have a direct answer, but I don't know if there is, yeah, if there is currently anything that uses more, like you said, more points to potentially decrease the side effects. But yeah, good thought, I guess. Well, if there are more questions, thank you so much. I really appreciate everyone attending, and thank you so much for your time.
Very well done. Thank you. You got it. You were efficient. You got it all done. We appreciate you.
Thank you.